Hi, everybody. We're back for chapter 11. These are drugs that affect the immune system. That starts on page 172. And this is, there's actually a box on page, read up about immunities and things like that. But focus on that box on 176. That's going to be a lot we're going to be talking about, and you kind of need to know that box. So we're going to go through the things. So innate, INNATE, which is a native immunity. This is what you're born with it. You had it at birth. You don't need to learn it through exposure, and it does help fight infection. So your innate or native immunity, that is what you're going to have at birth. That's going to help you, fight infections. Now, true immunity, body was once exposed to an organism. The body will actually learn that organism, and it will actually, if it gets invaded again, it can actually take care of it before you get ill because it has learned it and it knows how to take care of it. So our immune system always will help with this. So that is a true immunity. Now, when we talk about acquired, which is adaptive immunity, you're not born with it. It has to be learned. It learns the best way to attack the antigen and will develop memory for that antigen. It takes time to develop after exposure for the first time, but afterwards, if exposed to the same antigen, the body will remember it and then it will respond quicker and more efficient. So it's acquired. It's something we have to adapt itself to. So on page 176, like I said, the little box is there with the little pictures. That's going to be very important, okay? And we're going to go through each of those things, which is kind of thing. So first one we're going to talk about is the natural acquired immunities, okay? Now, naturally acquired immunities, and that's going to be the boxes on the one side, straight down where it has a little baby and then the baby inside the mama. That is going to be your natural corner. And then on the other side is the artificial, okay? So naturally acquired immunity, okay? This is when, and that is going to be, we're going to talk about naturally first. So our naturally acquired immunity, that is when you're exposed to an organism, for example, the flu or cold, and your body will naturally start developing the immunity to that organism. So the body, you were exposed, got sick, and your body just naturally starts working on that organism. Your body naturally acquired the infection, and your body naturally makes the antibodies to stop it. Okay, so that's naturally. Now, when we talk about the first box, naturally acquired active immunity, our own body naturally developed the antibody to an organism. This immunity is the strongest and the most long lasting. It will provide protection for decades. And this is the one that we like. And like I said, that will be examples of if you're exposed to a cold or the flu. That's where you're going to get your body actively makes it. It's a natural process. It naturally happened inside of you. And you actively are making something against that organism. And then if you are exposed to that organism again, you will have protection for a long period of time. Now, naturally acquired passive immunity, your body doesn't make the antibody. It is passed on through mom via the placenta or breast milk. And this is what keeps the infant healthy. The only bad thing about it is it only lasts for months. That's why the kids have to get multiple shots and things like that to protect them. So naturally acquired active immunity, you're exposed to some type of cold or the flu, and naturally your body makes it. Naturally acquired passive, mom passed it to the baby. It naturally occurred. We didn't have to inject them with anything. It naturally happened, but mom passed it on to the baby. So that is our natural column. Now we talk about the artificially acquired immunity. That's going to be the half of the block. Sometimes you don't want a person to become ill with an infectious disease, so we actually inject them with an antigen, which is usually like a vaccine or a toxoid, so they can actually stimulate the antibody production in the body and start making those antibodies to work against if you got exposed to an infection. So that's something that we worry about. Sometimes, the artificially acquired active immunity, let me see. If we're talking about the artificially acquired active immunity, this can last for many years. We usually give it at a younger age. We inject the body with antigens, and the body will produce antibodies or make a person resistant to a disease. So your artificially active is an injection. Those are all your booster shots, your MMR, your smallpox, your diphtheria, all those type of things. They're the vaccinations that we inject or ingest, because some of them are oral, an organism or an antigen to help produce an antibody that will hopefully prevent disease. And we do this by giving a vaccine. And of course, we know vaccines, they're substances used to produce antibodies and provide immunity against different diseases. They are prepared from the disease itself. Some of them are dead, some are weakened bacteria or virus, or they can be synthetic, man-made. So we use it as an antigen without causing the disease. So like the flu shot. The flu shot is basically a dead flu vaccination. A lot of people think that they caught the flu from the shot itself. Actually, no, you don't. Unless you have the oral one, the live virus one can cause some issues, but it's a dead vaccination. It's just a hope to boost your antigens. So what happens usually is you were probably sick prior to, and then the flu shot didn't have time in effect to make those antigens to fight the flu that you caught. But a lot of people mistaken the flu for something else. Usually it's just some type of virus. It's not the flu virus, it's just the flu. Not flu, but just the virus itself. It's not the flu. So artificially acquired active immunity is that they injected you with something, and then what happens is you will automatically produce those antibodies. And that's what comes with the flu shots, any of those vaccinations. So sometimes you need a boosting or a booster shot, which is an additional dose of a vaccine needed periodically to boost the immune system. An example of that would be like your tetanus and diphtheria, which they recommend every 10 years. Anymore, they're recommending it more frequently, like I think yearly if you have kids, and then we do it 5 years. So it just depends on what they're injecting you with. And immunization, of course, the desired effect of immunization, our desired thing is a successful vaccination, which a person actually will develop immune resistance to the substance in the vaccine. So that is our ultimate goal. Now, the last box, on the other hand, the artificial passive, and we'll be talking about this afterwards. Now, this is something where you need immunity ASAP. Okay, so you need a shot for something. Maybe you were exposed. It's immediate short-term protection. Okay, it's only a short-term that can happen, but it's going to give you protection for that period of time. And then later on, you're going to have to get a booster shot or an injection of some sort. It's usually made from animal or human product, and it's going to be something that you get like a one-time dose, and then later on, you can get something else. So, for example, RhoGAM. RhoGAM would be a artificially passive immunity. We give you the shot after birth, and we'll be talking about that, and it helps the system. Another thing is someone who's exposed to tetanus, and if they actually start having symptoms of it, what they can do is give you a big dose from a human they can produce it from, or that of an artificially a passive thing. They can inject it to you, put it through an IV bag, and that will give you the built-in immunity. But then you're going to have to get an artificial active shot. You're going to have to get a shot of it to keep that boost. So that's where active passive, it's something that you're going to receive from another person. So anytime that's something received from another person, we know that it's going to be highest risk for having allergic reactions. So we have to watch with that one. But we're going to be talking about that more. I just want to explain that when we talk about some of the other things we're going to be going through. Especially RhoGAM, we'll be talking about that. So there are 4 types of vaccines. One, we have the inactivated vaccines. And this is inactivated or dead bacteria or viruses. And like I said, that would be like the influenza, chlamydia, hepatitis, and rabies. Those are inactivated vaccines. They're inactivated or dead bacteria. The second one is attenuated vaccines. These are your live virus vaccines. They're modified live organisms that cannot reproduce and usually don't cause the disease. So they're non-reproductive ones. But what the problem is that they will, work on your system to help boost up your immunities. And examples would be measles, mumps, rubella, polio, and chickenpox, or all these attenuated vaccines. Now, when we talk about the attenuated vaccine, the most important thing I can say about that is never, ever, ever, ever give an attenuated vaccine to anyone who is immune compromised or if their immune system is suppressed, because you will actually cause that organism to grow because they don't have the ability to build up the immunity because their system's low. So we would never give an attenuated vaccine to anyone who's immune compromised or immune suppressed. So people who are on corticosteroids, people who are on those autoimmune disease and they're on those drugs like the DMARDs, we would never want to give them an attenuated vaccine. We would want to give them an inactivated form. We would not give them a live one. The third one is our toxoids, and this is a chemically modified toxin from a pathogenic microorganism, which is no longer toxic, but still will make you able to produce antibodies. An example of that would be the tetanus, diphtheria, pertussis, which is, we know, the whooping cough, which is a big thing we have to watch for kids, the HPV virus, and the HBV, hepatitis B, that we're concerned about as healthcare workers. So that's the third one. And the fourth one is our biosynthetic vaccine. These are man-made substances. They're similar to the virus or the bacteria. And examples of that would be the HIV vaccine, the influenza type B, that's more for like meningitis, pneumonia, epiglottitis in children. That we use that one for. Majority of our vaccinations are given when you are a child. You are given many HBA, HBV, HIV, pneumonia, polio, measles, mumps, rubella, the varicella, chickenpox, the rotavirus, HPV, meningitis, seasonal influenza. But then there are only some that we give as an adult, like seasonal influenza shots, pneumonia, shingles, which is the varicella virus, hepatitis A, hepatitis B. They work with animals. They can get a rabies vaccination. Some individuals have to be vaccinated when they travel to other countries. Example, if you travel somewhere else, you may have to get the yellow fever vaccine, the chloria, typhoid, malaria, anthrax, and even more, just depending on where you're traveling. You should get vaccinated for that. It's just very important, like I said, vaccinations when you're a kid, you have to remember, babies get more vaccinations than when you're an adult because their immune systems are very small. And think about it, if you give them it has to take time for those immunities to build up. And sometimes you have to do more than one dose because their systems are tiny. It's also very important to make sure if you're sick, your child is sick, you don't get them vaccinated because their bodies are always working already on that infection. And you introduce something that they're supposed to learn and make new antibodies, their bodies can't handle it. So we want to make sure that your child is not sick before you get those immunities. That's an important thing. A lot of people don't think about that. Another thing we want to talk about is that tetanus. And I said that is a fatal disease that affects the central nervous system. It can cause painful muscle contraction. Usually it's called lockjaw. It's due to the tetanus bacteria and it affects the entire body. You can get it by getting a cut or a wound or exposed to contaminated soil or animal or human feces. And this is something big. And like I said, if you do develop that, a lot of times you can get that if they have to and you start developing signs and symptoms, they will give you that artificial passive immunity. They will give you an infusion of that medication to help with that. And then later on, you're going to have to get a tetanus shot to help keep the immunity longer because it's only for a short period of time to help you through the crisis that's occurring right there and then. Another thing we need to talk about is seasonal influenza vaccinations. There are many strains of the flu out there. If you get the flu, you will develop a long-lasting, naturally acquired active immunity to that flu strand only. And remember, there's many of them. Okay, so you may have been sick one year with one thing and then had the flu the following year because there's different strands out there. And people have to realize that there's many out there. If a different strain of the flu comes out, then you can get sick again and you will develop immunity to that strain. Now, usually what happens is the CDC, and that's the Center for Disease Control, what they do is they determine what um, is going to be the flu of the year. And they usually get that by past years of what was actually seen and what occurs. So they will either pick like 3 or 4 strands of the flu that they will make into a flu shot so you can start developing those artificially acquired active immunities. These strands, you will be protected for many years. That's why it's important for everyone to get the yearly flu shot so they're protected from the different strands. Sometimes each flu shot, sometimes it's a win or miss, just depending on what the flu is. I always say it's like a fishbowl, and they go in there with all these little balls, and they swirl it around and grab out and say, let's treat this one, let's treat this one. But normally we see a lot of the influenza A and B. That is a big one, and that's usually always going to be in a flu shot. But there's other ones, like West Nile was a big thing. So just depending on what's out there and what's going on, that is how they determine what is going to be in the flu shot. And like I said, sometimes they win, make it good, sometimes they don't, just depending. So now let's go back to the artificially acquired passive immunity, which is that one I told you at the bottom, where it's for first quick immunities. It's for short-term immunization, and then you're going to have to get a shot afterwards to build up long-term immunities. So these artificially acquired passive immunities, antibodies are made from another person or animal that are injected into you. Anything artificial is an injection. So it's made from an animal or a person. The body recognizes these antibodies as foreign, and then what happens is the immune system will start to attack and get rid of them. It's only for short-term immunization. Example, hypertetanus, large amounts of that anti-tetanus we just talked about, how bad tetanus is. That's a big thing that they will inject. It's usually made from human plasma, and they are injected into individuals that have not been vaccinated against the tetanus shot. Approximately 1 week later, you should get the vaccine, the tetanus vaccine, the person, so they can build up their own artificially acquired immunities. And that's what we want them to do, because it's only going to provide you for a short-term care, and then afterwards you need to get the shot so you can build long-term immunity. Other examples would be a snake bite or rabies. If it's given for an animal bite, when you don't know if the animal has rabies or not, or a wild animal, that's another one that you get those quick injections. Ebola virus, they inject plasma from an infected person. It's highly concentrated of antibodies, and it helps the person recover from the disease. We use human plasma for artificial passive immunity. The donor and recipient must have blood types that match. So if we use any human plasma, we want to make sure that the types match. Another one, like I said, is RhoGAM. RhoGAM is an artificially acquired passive immunity that is used during and after pregnancy to an Rh negative woman who is having an Rh positive baby. Okay, majority of the time they do not know if your baby's going to be Rh positive or not. So if you are an Rh negative mom, just be prepared, you're going to get the RhoGAM shot. So anytime an Rh negative woman, but it has to be an Rh negative woman who is going to have an Rh positive baby. If it's an Rh negative mom having an Rh negative baby, there's no issue. It's the Rh negative mom having an Rh positive baby, okay? And if you are Rh negative and you are exposed to those red blood cells that are Rh positive, the body will start making anti-Rh antibodies to get rid of any Rh positive cells. Okay, so during labor and delivery, the fetus blood actually enters the mom's circulation. Okay, not many of these anti-Rh antibodies are made during the first pregnancy, so the child is not affected. Problem occurs with the next pregnancy. If the child is Rh positive, mom will make many more anti-Rh antibodies, which can cross the placenta and actually destroy the red blood cells of the fetus. And in time, that will lead to the death of the fetus. So that's why it's very important that if you are Rh negative, mom, that you definitely get the RhoGAM shot. Even though if you don't know if your baby's positive or negative, you always want to do that because it's going to protect you from future pregnancy mishaps that can occur. RhoGAM must be injected into the Rh negative mom right after the delivery of an Rh positive baby. And like I said, a lot of times they don't check what the baby's blood type is. So the majority of the time they will just give you the shot for safety precautions. The injection is made from other people. So we do need to make sure we check a blood type to make sure that we got the correct match. We do inject a large amount of this anti-Rh antibody in the mom so that they can attack the remaining Rh positive cells that are circulating in the mom's blood. This will prevent the mother of making her own Rh antibodies and getting her immune system involved. So if we inject her with this medication, her immune system doesn't have to take over because it's seeing something foreign. And that's what we want. We want them to prevent her immune system taking over and getting involved. So without activating her immune system, there's little or no anti-Rh antibody in the body for the next pregnancy because ours took care of it. So she does not have to worry and it won't attack the Rh positive fetus. But if she has another baby, she will get another RhoGAM shot because that's for future pregnancies too. Now, anybody who has a miscarriage and they are Rh negative, they will get the RhoGAM shot. Anybody who is bleeding during pregnancy, they're not miscarrying, they're high risk for miscarriage, but they may be vaginal bleeding. Maybe they had abdominal trauma. Then they may give them the RhoGAM shot, even though they have not had the baby, because there's risk for blood to be mixed, especially when you're starting to have vaginal bleeding. It could be some tearing of the placenta or something that could be causing mixture of blood. When you have trauma, if you get hit in the belly, that could be a mixture of blood. So that's why a lot of times, if we know that they are pregnant, we will make sure that we give them RhoGAM, but it's usually with the Rh negative moms that we will give them to, because we don't know if their babies are positive or negative, but we're concerned that the mixture of blood and that it could actually kill the fetus. That's why when trauma patients come in, we make sure that we give them we give them O neg blood. We don't give them O positive blood. We give them O negative blood. So any female that comes in, we don't know what their blood type is. We give them O neg. We never give them O positive because those positive cells are what's going to attack and cause issues if they're pregnant or planning to become pregnant. It can cause issues to it. So that's something, just food for thought on that one. So considerations for vaccinations. Of course, the pediatric population, when you get most of your vaccines, you must be followed the regimen for the best effect. Never give it to them when they're sick because their body has to make the antibodies when they're sick, and then you're going to give them more stuff that's going to cause problems. Your pregnant and breastfeeding population, you can give vaccinations during pregnancy. They have the live virus vaccines, can be given 1 month before pregnancy, but not during pregnancy. An example of that would be your measles, mumps, rubella, polio, and chickenpox. And it's always recommended to get the flu shot during any time of pregnancy. It's also recommended to get the Tdap, which is tetanus, diphtheria, acellular pertussis, and vaccinations anytime during any time of pregnancy. If you're traveling out of the area, it's very important to make sure that you talk with the physician because you may need vaccination depending on those countries. Now, our older populations, when we're doing vaccinations, your immune system, things as you get older, things decline. And as you get older, those antibodies that were developed may start to diminish over time. And this leaves this population at risk for infection and disease. That's why a lot of times you will see people with shingles, okay? So think as a child, you had the chicken pox, and then later on that immunity that you build up for it starts going away. And that's why people get shingles, okay? Because it's from the varicella zoster virus that is in chickenpox. It's reactivation of the virus that lay dormant after exposed to chickenpox as a child. And as you get older, the antibodies are fewer. And so both naturally acquired active immunity and the artificially acquired active immunity becomes diminished, and that's why it's required to get revaccinated. You also have to remember what that is. You have to have chickenpox in order to get shingles. If you've never had chickenpox, then you won't get shingles. Okay, but you've had to have some form of chicken pox. And like I said, my mom never showed any signs of having chicken pox, but all her kids had chicken pox. So not saying she wasn't exposed, or she may have had some type of breakout, maybe internally something happened, or she didn't know she had it, but she had to have had chicken pox or something wise, because later on she got shingles. So you've had to have some exposure to chicken pox in order to get shingles. And the big thing with it is, if you have never had chicken pox, you do not need to get the shingles vaccination. Okay, so a lot of times we check for titers. So if your titer was 0 for chicken pox, it does not mean you need to get the shingles vaccination. Okay, so a lot of people do have to realize that. Right, so that's information about immunization. Now let's talk about immunosuppressive therapy. And this is very important because these are something that people have to take and be on alert. So sometimes our immune system gets out of control, and it will actually start attacking it until it causes damage to the body and tissues. And we talked about this in past chapters, especially with the corticosteroids, our anti-inflammatories, our DMARDs, things like that. So example of that would be allergic reactions, some autoimmune disorders we talked about, like lupus, myasthenia gravis, rheumatoid arthritis, psoriasis. This is when we need the immunosuppressant drugs to help our body stop the process. We can use these drugs also to decrease the normal activity of the immune system, especially for our organ transplant patients. Our organ and tissue transplants, if we don't give these immunosuppressant drugs, what can happen is the immune system will start attacking these organs that they got because they consider them as foreign. So that's why we want to give them these immunosuppressant drugs to prevent that from happening. So patients with autoimmune disorders, or if they've had any type of transplants, are put on these special medications to prevent those things. Before, many transplant patients died due to infection because of their weakened immune system. But now we have better drugs. They are more selective. They're called selective immunosuppression drugs that suppress the cells responsible for organ rejection. So they're more specific. They're not general. So it does help us more with that. Transplant patients that are on these anti-rejection drugs, they need to be on them for the rest of their lives. And many have to take a combination of the drugs. And you'd be amazed, anybody with them, they will be all on it. They will be like, time, I need my drugs. Time, it's time to take my drugs. And I don't blame them. You've been put on a list for many years to get an organ. You finally get an organ, I'd be treasuring that organ. And I'd make sure that I'd be taking my medication faithfully, because I wouldn't want to have rejection and then have to go back through that process. But because think about it, once you start rejecting it, the body starts attacking it because the immune system isn't suppressed. It's going to attack that organ and can actually probably kill the person because, you know, time and depending on what organ or tissue that was, done. So we're going to talk about the 4 types of immunosuppressant drugs, and we've already talked about some, so that's the nice part. The first one, corticosteroids, which we already talked about. Remember that's example like prednisone, hydrocortisone, that was back in chapter 6. Another thing we talked about, the second one, is the DMARDs, the disease-modifying anti-rheumatic drugs, which we talked about. And that was the adalimumab and etanercept. Those are those 2 injectable ones that we talked about. The third one is going to be the cytotoxic drugs. These ones kill cancer cells, and we're going to discuss that in the next chapter. And then the fourth one is what we're going to talk about now, is our selective immunosuppressants. These are the ones we're going to be discussing. So those are the 4 types of immunosuppressant drugs. And like I said, we've already talked about 2 of them. The next chapter, we'll talk about the cytotoxic drugs, and the selective immunosuppressants are more specific and where we're going to go. All right, so when we talk about the selective immunosuppressant drugs, these drugs work on the immune system that target the cells of the autoimmune disease or the transplant rejection. So they will not attack the entire immune system. They're going to be more specific. They're usually prescribed in a combination of different drugs to help prevent the transplant rejection. The only sad part is there are four categories of selective immunosuppressant drugs. And let me flip to that lovely page in the book, because I'm still on the little picture box that you guys have to kind of know. Get to there. So on page 185, And 186 are your common immunosuppressant drugs out there. Okay, so those are the ones to look at. Now, the first one we're going to talk about is the anti-proliferatives. These are used for autoimmune disease and also transplant rejections. The second one is your calcineurin inhibitors. The third is your monoclonal antibodies. These are antibodies produced by a mouse or a combination of mouse and human, which we mostly give, that bind to a target and prevent the attack of transplanted organs or tissues. They don't affect any other types of immune system cells. Majority of the time, these ones are going to be given IV. They're very effective at initially preventing acute transplant rejections. So if you're starting to have a rejection, they're going to be giving you these IV things. So monoclonal antibodies are thing, and they're only used for a short period of time. Then they'll put you on pills. Now, the bigger one is the polyclonal antibodies, okay? These are antibodies that are made from animals like horses and rabbits. They can cause profound immunosuppression. They are used for acute rejection episodes after a kidney transplant. And it doesn't work on other types of immune suppressive therapy. And again, this one is used for short term for therapy. So if you think about it, monoclonal, mono, one, poly, many. So out of all of these ones, polyclonal is going to be the worst ones. But both monoclonal and polyclonal, you have a high risk of having allergic reactions because it's made out of human or some type of animal component. So you're at higher risk for anaphylactic reactions when it's actually given from another human source. All right, so side effects for these drugs. You're going to have some degree of immunosuppression, which we know will put the patient at risk for infection. If it's not given, if you have systemic infections, it's most common for all four categories. You can have GI disturbances and a variety of rashes. Sirolimus and everolimus can increase your serum cholesterol levels. So if you have cholesterol problems, those can make it worse. Calcineurin inhibitors can cause hypertension, elevated serum cholesterol levels, and hyperglycemia. So you'd have to check your blood sugar more frequently if you're on calcineurin inhibitors. And your cyclosporins can cause the gingival hyperplasia. I always call them horsey gums. Those are a lot of times you see that people, like if they take certain seizure medications, their gums kind of build up and they get these thick, big gums, horsey gums, I call them. But it's gingival hyperplasia, and that's a side effect of the cyclosporins. Adverse effects, there are risk for bacterial and fungal infections. All of them increase your risk for cancer. All of them increase your risk for cancer. The risk will increase when you're on it for long term. So your anti-proliferatives and your calcineurin inhibitors, you're at higher risk for getting cancer. Because think of it, the monoclonal and the polyclonal are IV and is short term. Of course, your other ones, your anti-proliferatives and your calcineurin inhibitors, you're on them for a long period of time. So you're at higher risk to develop cancer because you're on those. They are big time liver toxicity, liver failure, especially your anti-proliferatives and your calcineurin inhibitors. If you give it IV, phlebitis and thrombosis can occur. And of course, it can cause electrolyte imbalances. So it can cause potassium imbalance, phosphorus, magnesium, especially when you're on the anti-proliferatives and the calcineurin inhibitors. Those are the ones you have to be careful with. And like I said, allergic reaction or anaphylaxis can happen to any of these drugs, but much higher risk if you're taking the monoclonal antibodies, and even a higher risk if you're taking the polyclonal antibodies, because those are made of the human products. So before we give these meds, we always want to use personal protective equipment. So PPE is very important when handling any anti-proliferative drug, because it actually will absorb through your skin and your mucous membranes. Of course, we want to make sure that we get all medications the patient's taking, over the counters, any herbals, any allergies that they may have, because we need a list, because we want to make sure we avoid any interaction with drugs. We want to make sure that they have no liver problems. So we're going to be checking a liver function test beforehand because these drugs can cause a lot of liver problems. We want to make sure that they're not allergic to the mouse protein, because if that's the case, you can't have the monoclonal antibodies. And I don't know if anybody knows if they're allergic to mouse protein. I don't know. You probably have to do some allergy tests to determine that one, because I wouldn't be able to tell you, yeah, I'm allergic to mouse protein. No. And some of them, if they give those like monoclonal or polyclonal, because of the bad adverse reactions that occur because of the risk for allergic reactions, they may want to pre-medicate them beforehand. So they may want to give them some diphenhydramine Benadryl or something to help prevent those allergic reactions. And the monoclonal or polyclonal antibodies, we want to prevent those allergic reactions. So we need to be prepared in case there's an emergency, something happens. So we want to make sure we are prepared to take care of them. After we give, we're going to always monitor, check their CBC, we'll check their liver functions. We're going to monitor a patient when getting IV infusion, because we're going to watch the patient, we're going to watch the IV site, especially the monoclonal and polyclonal. We're going to be looking for any allergic reactions. We're going to watch for liver problems because we know that's very bad for the liver, and we're going to recheck those liver function tests. And also remember, repeat those electrolytes, potassium, phosphorus, and magnesium we have to watch. We're going to teach our patients to report any signs and symptoms of infection. They need to report it ASAP because their immune system is going to be compromised. We're going to make sure we keep monitoring those lab work, CBC, liver functions, electrolytes. But most important, we need to teach them to take the meds as directed to maintain the effectiveness. If they miss a few doses, it can actually start causing tissue damage and transplant rejection. So that's why it's very important to make sure they maintain a perfect level and they take it every day faithfully and try to take it on time. Of course, we're going to teach them about liver problems, when to report, like jaundice, the urine, the stools. They cannot drink alcohol and they cannot take Tylenol while they're on this, or acetaminophen while they're on this medication. And they do recommend drinking a full glass of water when they take it. No grapefruit juice, especially when you take the oral dose of sirolimus or tacrolimus. That's important to know. So no grapefruit juice. Add it on your list. Now, here's another way of mixing, and you need to know this. The oral suspension of sirolimus or cyclosporin, you must mix the drug as directed. Don't use water, but milk, okay? You can use milk, you can use orange or apple juice, but you cannot mix it with water, okay? And after you take it, you must rinse the container with the same solution you mixed and swallow it down. So that's important to know. So remember, oral suspension, that's liquid suspension of sirolimus, you can mix it, or cyclosporin, you can mix it with milk, orange, or apple juice. And then after you take it, you rinse the container out with the same solution and drink, but no water on that one. They say cyclosporin you can mix in a glass container. Who cares? I guess they do. And then on both the oral sirolimus and the cyclosporin, make sure you take at least 4 hours apart. So if you're on both of those medications, you have to spread them out 4 hours apart because they will interact with each other. In pregnant and breastfeeding population, anti-proliferatives, poor pregnancy outcomes. You should not get pregnant if you're on the medication. So that's a teratogen. So you have to use 2 forms of contraceptives while you're on the therapy, and 12 weeks after, and no breastfeeding at all. Okay, so this is a very important. You're going to make sure you're not pregnant before you take it, and you have to continue, protecting yourself for 12 weeks after you're off the therapy. And calcineurin inhibitors and the monoclonal and the polyclonal antibodies will still have some harm to them. It can cause some defects, and of course, none of them are recommended for breastfeeding. But the issue is, even if you're pregnant, you still have to take the medication, because if you don't take the medication, it can cause anti-rejection issues. And if you reject an organ, it could kill you and the baby's going to die. So sometimes, the risk and the benefits, if mom dies, baby's going to die. So sometimes the medication, you have to take the medication, even though it does put you at risk for having birth defects. So that is the next chapter. That is chapter 11. So if you have any questions for me, I will discuss them with you at any time. Have a good one, guys.